Hello, everybody, and welcome to the GLODERM Training Committee Alopecia Awareness Series. My name is Linda Atten, and I'll be your host today together with Karen. GLODERM Training Committee is a trainee arm of GLODERM, and that is the International Alliance for Global Health Dermatology. The International Alliance for Global Health Dermatology is an official program of the International Foundation for Dermatology under the International League of Dermatological Societies, ILDS. The mission of the GLODERM Training Committee is to promote knowledge equity by improving access to education for dermatology trainees worldwide. We also aim to provide free educational events and opportunities to build networks and collaborate. September is Alopecia Awareness Month. This month is dedicated to raising awareness for alopecia and all related hair disorders, aiming to increase medical understanding and also the patient impact. This matters because it helps to promote earlier diagnosis, access to patient-centered care, and also supports advocacy for improved treatment options. It supports ongoing education and also evolving therapies and multidisciplinary management. How can you get involved in alopecia awareness? You can participate in our educational webinars and discussions. You can also share your clinical insights and resources with colleagues and also patients. You can engage with patient advocacy groups and research initiatives. You can also promote awareness via your clinics and also social media platforms and any other media platform you're aware of. So for this alopecia awareness series, we have a series of topics which we'll be discussing today. We'll discuss the basics of alopecia diagnosis and clinical cases, treatment trends, and research. We'll also do a live Q&A session. But for each session, of course, we have very notable speakers that will be talking to us and sharing their clinical experiences with us. For the remainder of this webinar, your audios will be muted, your cameras will also be turned off. If you have any questions or comments, please submit it via the YouTube chat function. Our speakers will also answer your questions during our live speaker panel later. I'll also be sharing information about GLODERM Training Committee and how to get involved in the YouTube chat box. Introducing our speakers for the basics of alopecia. We have Dr. Nkechi Enechukwu from Nigeria, and we have Professor Maria Hordinsky from the US. So introducing our first speaker is Dr. Maria Hordinsky. She's a professor and vice chair of research at the Department of Dermatology Medical School, University of Minnesota. She's a tenured faculty member, also the vice chair of research and immediate past chair of the department. She is recognized for her expertise in research in hair disease and peripheral nervous system as it relates to hair follicle biology. She is also the past president of the American Hair Research Society. She regularly lectures and teaches on hair diseases and divides her time between seeing patients with residents and medical students in her clinical practice at the University of Minnesota. Thank you very much, Dr. Maria. We are glad to have you here.
Welcome to the presentation on basics of alopecia. My name is Dr. Maria Hordinsky. I'm on the faculty at the University of Minnesota in Minneapolis, Minnesota, and I'm a professor and vice chair of research in the Department of Dermatology. In this presentation, I am going to talk about the hair follicle. We talk about the follicle as being part of the pilosebaceous unit, as you can see on this cartoon picture. The hair follicle is amazing. It demonstrates its unusual ability to completely regenerate itself. Hair grows, hair falls out, and then it regrows. And if you pluck a hair, it will also regrow. There are very important cells for the creation of new hair follicles. The most important ones are your epithelial stem cells in the bulge region, as shown in the cartoon figure on the right. This region is protected by the insertion of the erector pili muscle into that hair follicle region as part of the pilosebaceous unit. This is an example of a normal scalp biopsy. This is a picture taken of a vertical section from a 4 millimeter scalp punch biopsy, and one can see the beautiful hair follicles extending deep into the subcutaneous. This is a cross-section of a normal human scalp hair follicle, and here you can see what are called follicular units. These units consist of 2 to 3 or 4 follicles, and in the normal scalp, as in this picture, the follicles are primarily in the anagen phase. So one sees very few telogen follicles or catagen follicles. Here we have a beautiful picture of the bulge region showing the innervation of the hair follicle. You see in green, the nerves are stained, and you can see the rector pili muscle staining there. And you can see the blood vessels in red. And if there's co-localization, one will see a yellow color, as shown in some regions. This very interesting structure, the hair follicle, produces hair fibers, and there is a hair cycle. 90% of the follicles on the scalp are thought to be in the growing phase for 2 to 7 years. And in the catagen phase, the transition phase, about 2 to 3 weeks, and the telogen phase, about 2 to 3 months. And you can see on your lower left a picture of pulled telogen hairs. Patients will frequently describe their hair as falling out by the roots on this picture. And on the right, you'll see anagen or actively growing hair fibers, which look like they have a broomstick at their end. To understand the basics of alopecia, one had to have that fundamental understanding of the hair follicle structure. So you can see how hair diseases could occur for many reasons. For example, if the hair fiber is not normal because of genetic reasons, or if someone has been using too many chemicals on their hair, or perhaps someone is pulling on their hair, one could have hair loss or alopecia. One could also have cycling issues like you see in telogen effluvium or alopecia areata. One could also have miniaturization of the hair follicle. So instead of growing deeper into the skin with each cycle, it becomes shorter. And that you could see with androgenetic alopecia, commonly called male or female pattern alopecia. And then lastly, we have those diseases that target that bulge part of the hair follicle, causing scarring and permanent injury. This slide demonstrates a young man with monilothrix, a structural hair abnormality, which when you examine the hair fiber under the microscope, one will see a beaded pattern, which will be shown on the next 2 slides. When patients have this inherited structural hair abnormality, the hair is very fragile and can break easily in the areas of fiber thinning. This is a trichoscopic picture taken from a patient with monilothrix, and one can see this beaded pattern of the hair fibers, which you will see more closely when one takes one of these fibers and puts it under the microscope and examines fibers individually. And here we see this beautiful beaded pattern that is characteristic of monilothrix. And you can see here the 3 major layers of the hair fiber: the cuticle, which looks very good, the medulla, which is an airspace, which in this particular hair fiber is interrupted, and then the cortex, which will be the pigment, the brown pigment, light pigment in the major part of the hair fiber. Here we have a patient who has a chief complaint of hair loss. And when one takes his hair fibers and takes a look at them under the microscope, one sees bubbles, as will be shown on this next slide. So bubble hair arises when one uses high heat, as with a hair dryer, on wet hair, and the water within the hair fiber bubbles, making the hair fiber very fragile or potentially fragile, so that with combing or brushing, the hair may break easily. Here we have an example of a young woman who actually pulls at her hair, and this is called trichotillomania, or compulsive plucking or pulling of hair. And the hair fibers will be at different lengths, and there may be unique patterns of hair loss as shown in this particular picture with this triangular, well-defined area of hair loss. Next, we will talk about the hairless mutation as an example of a mutation that affects the hair cycle. So when patients have a mutation in the hairless genes, the hair follicle development is normal, but the hair follicle falls apart during catagen, and that dermal papilla, that lower part of the hair follicle, never moves upwards, and cycling actually ceases. In this slide, you see the impact of a mutation in the hairless gene on hair follicle cycling. So this patient looks like he has alopecia universalis, but he was born with hair. But when the hair cycled, it could not maintain that cycling pattern characteristic of the normal hair cycle in normal individuals. And you can see on the right here where there is no connection from the hair follicle unit in the lower part of this picture to the epidermis. Next, I'd like to focus on short anagen syndrome as well as loose anagen syndrome. So short anagen syndrome is characterized by the anagen follicle not producing a long cycle. So there is this inability to grow long hair. And when affecting children, parents will typically bring their children to clinics saying their child's hair will not grow. So there we have an example of short anagen syndrome. Here we see a child with loose anagen syndrome. Frequently, as noted before, parents will bring their children, an affected child, to clinic with the chief complaint that their child has never had to have a haircut because the anagen phase of the hair cycle is very, very short. This is in contrast to loose anagen syndrome, where when one lightly pulls on the hair comes out very, very easily. In the other condition, the hair is tightly still present in the skin, and it's much harder to pull out. Here, a light hair pull test produces several anagen fibers, which will be shown in the next slide. Here we have an example of a loose anagen fiber. There is the presence of a longitudinal groove, an absent root sheath, and this characteristic ruffled cuticle. This is what the fiber that is loosely present in the skin of the child with loose anagen fibers. When you lightly pull these out, this is what these will look like under light microscopic examination. So for the basics of alopecia, we have covered the structure of the pilosebaceous unit with a focus on the hair follicle. We focused on the product of the hair follicle, the hair fiber, and we also focused on hair cycling. So now I would just like to talk a little bit about some of the hair diseases that we see that are related either to immunologic abnormalities as seen in alopecia areata on the left in this slide, scarring alopecias where the bulge region of the hair follicle is impacted by inflammation, something we see in frontal fibrosing alopecia like in planopilaris and central centrifugal cicatricial alopecia, and pattern hair loss in women and men where we see a miniaturization of the hair follicle occur. The first disease that will be presented is alopecia areata. This immune-mediated disease can occur as limited patchy disease, as shown in the upper left quadrant of this slide. It can be very extensive patchy disease, or the disease can affect every single hair follicle on the body, including eyebrow hairs, eyelash hairs, beard hair, extremity hair. Alopecia areata can also present itself in what's called the ophiasis pattern, as shown on the lower right-hand corner of this slide. And again, on this slide, we see children affected with alopecia areata. Experiencing alopecia areata can be psychologically devastating to many people, but now with new tools and new treatments, we're in a new era in the management of patients affected with this immunologically mediated disease. Alopecia areata is characterized in its active stage by this inflammation, these lymphocytes surrounding the lower part of the hair follicle. And these lymphocytes can invade the hair follicle. They have been well characterized, and treatments now are focused on those T lymphocytes as well as cytokines associated with the production of this inflammatory process in the skin. Next, I'd like to just comment about the hair disease that we see where the follicle miniaturizes. So at puberty, there are selective roles for testosterone T on this slide and DHT, dihydrotestosterone. So in the male patient in particular, testosterone and dihydrotestosterone play a major role with the hair follicle. So one will see in males a growth of terminal hair in the beard region, limbs, body, external ears, and nostrils, as shown in the column on the right side there. And what this translates into clinically is androgenetic alopecia or male pattern baldness, quite extensive male pattern baldness is shown on your left. And in women, the pattern tends to be a little bit different and is probably more multifactorial, where one can see usually the retention of the frontal hairline and widening of the part width in characteristic female pattern alopecia. Balding in men and women follows a pattern in large part. The most characteristic pattern for males is that shown on the left, known as the Hamilton-Norwood classification system, where the balding starts with bitemporal recession, then thinning in the vertex region, then the two regions meet, Another type of balding frequently seen in men will be a very quick loss of hair in a frontal posterior pattern. In women, we have different scales. Two are shown on this slide. One is the Savin scale, where one looks at the balding pattern and thinning being as mild, moderate, or severe. And then the Savin scale down below the Ludwig scale shows a little bit more differentiation, taking into account not just the part width, but also the density. Next, I'd like to talk about the cicatricial alopecias. So scarring hair diseases can occur either as primary alopecia conditions, or they could be secondary. An example of a secondary scarring alopecia would be if someone sustained a burn or chemical injury to the scalp, and there was destruction of this bulge region of the hair follicle, resulting in permanent injury to the stem cell region. This picture is being shown again just to show once more the complexity of the bulge or stem cell region. And this is where the destruction occurs in the majority of the cicatricial alopecias. There are several cicatricial alopecias. Four of the more common ones are shown on this slide, lichen planopilaris, central centrifugal cicatricial alopecia, frontal fibrosing alopecia, and discoid lupus erythematosus. The cicatricial alopecias are still generally broken down into those that are primarily lymphocytic versus neutrophilic. In this particular presentation, I'm just showing the lymphocytic cicatricial. A relatively new cicatricial alopecia, first described in the mid-90s, is frontal fibrosing alopecia, where patients can experience symptoms as itch, burning pain, skin crawling sensations, redness. Clinically, one sees perifollicular erythema and scale, and recession of the frontal hairline with changes in the vein architecture of the forehead regions, with veins either being depressed or raised or neutral. The disease now also has been shown to affect the lower posterior scalp. It is a disease whose etiology is still unknown and is a subject of research by many investigators. Lichen planopilaris is another inflammatory scalp condition where one sees perifollicular erythema and scale. When it occurs on the scalp, one can see these areas of whiteness as shown on the second figure on the upper right. Where there is scarring, there's also disease activity with perifollicular scale and erythema, and one can see the destruction even histologically as shown on the histopathologic slides on the lower part of this slide. Another more recent alopecia that's been described is fibrosing alopecia in a pattern distribution, or FAPD. And this is a situation where one looks at the female patient in particular and sees androgenetic alopecia, but when you look closely or if you biopsy, there actually will be a fibrosing or inflammatory cicatricial alopecia process going on, and many times both conditions are present. It is a condition that also affects males. On this slide, you see an example of very extensive fibrosing alopecia pattern distribution, and one would have to think here too of androgen excess, if there was something wrong with this patient's adrenal glands or ovaries. So a good workup would be indicated, as we do with all of our alopecia patients, but at the end, the diagnosis of fibrosing alopecia in a pattern distribution was made. This is an example of the right parietal region, and on closer inspection, one will see the perifollicular erythema scale characteristic of these lymphocytic cicatricial alopecia. The last lymphocytic scarring alopecia I would like to discuss is central centrifugal cicatricial alopecia, also known as CCCA. So in this condition, we see it primarily in women of African descent. There's a scarring process that occurs in a centrifugal pattern in the mid part of the scalp, and it diffuses outwards. You can see on the lower right picture a dermatoscopic picture that shows the characteristic perifollicular erythema scale, absence of hair fibers, and if one sees white patches, then there's definite scarring that is present in affected individuals. So in conclusion, thank you for your attention on this journey about the basics of alopecia. I've taken you through the journey of exploring the hair follicle, its product, and some of the diseases that can be associated, whether they be immunologically oriented or hormonal or other. Again, thank you for your attention.
Our second speaker is Dr. Nkechi Enechukwu. Dr. Nkechi Enechukwu is a senior lecturer and honorary consultant dermatologist and venereologist at Nnamdi Azikiwe University Teaching Hospital, Nnewi, Anambra, Nigeria. She is also a visiting scholar at the School of Medicine and Allied Health Services, University of the Gambia, Banjul. She has a fellowship in dermatology and venereology from the National Postgraduate Medical College of Nigeria, and also an advanced subspecialty training in trichoscopy from the Medical University of Warsaw, Poland. Her work focuses on hair and scalp disorders in individuals with skin of color. She has an extensive research and publications on both scarring and non-scarring alopecia. Thank you very much, Dr. Nkechi. We're glad to have you here.
Hello everyone. I thank the GLODERM Trainee Committee for the kind invitation to talk about clinical overview of alopecia. My name is Dr. Nkechi Enechukwu from Nigeria. In the course of this lecture, we will be learning how to define alopecia, how to identify key contributing factors to alopecia and their impact on follicular health. We'll be differentiating between scarring and non-scarring types of alopecia. We would learn to recognize the major clinical subtypes of alopecia and their distinctive clinical presentations. We would also learn how to apply a systematic approach while we are evaluating the patients that present to our clinics with alopecia, with the aim of establishing the appropriate diagnosis. As we know, making a correct diagnosis is key to appropriately managing these patients. So first, we want to know what alopecia is. Alopecia means hair loss, and it actually manifests as a reduction in visible hair in hair-bearing areas, including the scalp, the eyebrows, the eyelash, the body hair, and in postpubertal individuals, the axillary hair and the pubic hair. Alopecia is actually a manifestation of a wide variety of disorders and has varied clinical presentation depending on the etiology. The pathogenesis of alopecia varies, and it ranges from congenital causes like an absence of hair follicles that is seen in conditions like Alopecia cutis congenita, to destruction of hair follicles by autoimmune or inflammatory processes. Disruption of normal hair growth cycle can also cause alopecia, where you have an altered anagen-catagen-telogen balance, leading to excessive shedding of hair cells or hair follicles, or miniaturization. Also, abnormalities of hair shafts that makes them fracture easily can also cause alopecia. Finally, a combination of these mechanisms can also come to play in certain forms of alopecia, as we can see in the subsequent slides. Now, to highlight the key contributing factors of alopecia, things like genetics play a lot of role in some alopecia types, like in the hair shaft disorders, in some scarring forms of alopecia like central centrifugal cicatricial alopecia, and then even in female pattern hair loss, frontal fibrosing alopecia, and male androgenetic alopecia. Hormones also play a role in male androgenetic alopecia, female pattern hair loss. Autoimmune causes like alopecia areata, discoid lupus erythematosus, and lichen planopilaris are also noted as contributing factors to alopecia. Infections like syphilis, fungal infections, stressors like psychological stressors, emotional stressors, physical stressors, drugs, hairstyling practices, dietary practices are all factors that can contribute to alopecia. Now, quickly, let's have a recap of the hair biology, and it will help us. So here, the stem cells are located in this bulge area, and any inflammatory process that can affect the stem cells would lead to an irreversible hair loss, meaning that the hair follicle, once it's lost, is permanently destroyed. Now, when we have things that interfere with this dermal papillae and the hair bulb matrix, it interferes with the ability of the keratinocytes to proliferate, and then it can lead to alopecia. But this time around, if the stem cells are spared, then it can cause a non-scarring type of alopecia. Alopecias are basically classified into scarring alopecia, non-scarring alopecia, and structural hair disorders. In the scarring alopecia, like we mentioned earlier, a scarring process or an inflammatory process affects the stem cell areas, the bulge area, such that even when the hairs follicles are destroyed, there is no propensity for regrowth. In the non-scarring forms, the stem cells are preserved, so regrowth is possible. For the structural hair disorders, the hair shaft is fragile at some certain points and fractures easily, leading to alopecia. So these highlight the varied causes of the different classifications of alopecia, and we're going to look at some of them in the course of this lecture. So first, we start with the scarring alopecias. Scarring alopecias are divided into primary scarring alopecias and secondary scarring alopecias. In the primary forms, a primary scalp disease affects the hair follicles, causing destruction of the hair follicles, including the stem cells. So there is no regeneration. Now, it's classified based on the primary inflammatory infiltrate seen on histology into neutrophilic forms, lymphocytic forms, and mixed forms, where you have both neutrophils and lymphocytes predominating in the histopathologic picture. So we'll look at one of them, folliculitis decalvans. It's a chronic neutrophilic scarring alopecia that is associated with abnormal immune response to Staphylococcus aureus. It presents at the acute phase with recurrent crops of pustules, crust, and perifollicular erythema, which may not be appreciated in dark scalps. Now, over time, this leads to patches of cicatricial alopecia with tufted folliculitis. And these tufted folliculitis or tufted hairs are actually multiple hairs emanating from a single hair follicular opening. So you can see hairs as much as 20 to 50 to 100 hairs emanating from the single hair follicular openings. In Caucasians, folliculitis decalvans may present similar pattern, but you have lots of erythema, which is very visible, as we can see here. Dissecting cellulitis of the scalp is another chronic neutrophilic scarring alopecia that is very common in blacks. It presents with painful nodules, abscesses, and draining sinus tracts on the scalp. And over time, these form boggy fluctuant plaques with scarring alopecia. It is thought to occur from follicular occlusion from abnormal follicular keratinization. Secondary bacterial infection can supervene, worsening the disease. Occasionally, dissecting cellulitis of the scalp can present as a triad or a tetrad. In this case, you have dissecting cellulitis of the scalp co-occurring with hidradenitis suppurativa and acne conglobata. The fourth condition in the tetrad is a pilonidal sinus. Discoid lupus erythematosus is this time around a chronic lymphocytic scarring alopecia form. It has an autoimmune basis. It presents at the early phase with erythematous scaly plaques with follicular plugging. And these follicular plugs are seen as spiky follicular opening, spiky spikes occurring over dilated follicular openings, and is typically called the carpet tax sign, which we can see here. Over time, it progresses to atrophy with pigmentary alterations and permanent hair loss, as we can see in this particular patient. The lesions are often photosensitive and may worsen with sun exposure. Discoid lupus erythematosus can occur in isolation as part of chronic cutaneous lupus erythematosus. Also, in some situations, it may occur together with systemic lupus erythematosus. Now, sometimes in these patients, lesions may extend to the conchal bowls, which is one of the key markers that can differentiate discoid lupus erythematosus from other scarring alopecia forms. So in the conchal bowls and even the neck, and indeed even the other photosensitive areas like in the face. Now, dilated or patulous follicles are one of the key findings. Even without trichoscopy, these may be visualized. And we can also see that there are areas of pigmentary alterations ranging from hyperpigmentation to hypopigmentation. Lichen planopilaris is another chronic lymphocytic scarring alopecia. It's an immune-mediated disorder with lymphocytic inflammation targeting follicular antigens and causing a cytotoxic reaction. There are 3 variants, including classic lichen planopilaris, which actually presents with patchy areas of scarring alopecia. There is often associated follicular papules, perifollicular erythema, and scaling. Patients may complain of itching or burning sensation over the affected areas. Oftentimes, the patient may also have concurrent cutaneous lichen planus or nail lichen planus. Trichoscopy would typically show perifollicular hyperkeratosis, which presents as perifollicular scaling. And in the dark skin phototypes, these erythema may barely be seen in these particular patients. Frontal fibrosing alopecia is the second variant of lichen planopilaris. It presents with a band-like area of scarring alopecias at the frontotemporal area and is characterized by progressive frontotemporal hairline recession. Occasionally, the eyebrows may be involved. The posterior hairline may also be affected. The body hair rarely may also be affected, although it's very uncommon. One of the key features on trichoscopy is the absence of vellus hairs in the field and the lonely hair sign, where you see a single hair shaft emanating from a follicular unit in an island of an area with scarring alopecia and no vellus hairs. Additionally, the pseudo fringe sign, which is retention of terminal hairs along the anterior hairline, may also be seen in some cases of frontal fibrosing alopecia. The third variant of lichen planopilaris is the Graham-Little syndrome. Central centrifugal cicatricial alopecia is a chronic lymphocytic scarring alopecia that is common in Black African females. In the early phase of the disease, the patient often presents with a scarring alopecia type associated with widened pathways, especially at the vertex. Over time, this progresses to affect surrounding areas of the scalp in a centrifugal manner. It is thought to occur from a primary premature desquamation of the inner root sheath, which leads to follicular rupture, facilitating entry of environmental insults like chemical hair relaxers into the lower portion of the hair shaft and inciting chronic inflammatory response, causing damage to the hair follicles. There is also an associated loss of function mutation of the PADI3 gene in familial cases of CCC. So there's a combination of genetic and environmental factors here. Patients may often complain of pain, itching, or dysesthesia over the affected area, although sometimes it may be asymptomatic. Trichoscopic features include the perifollicular halo, which is a hallmark trichoscopic feature in Acne keloidalis nuchae is a chronic scarring alopecia type that has mixed inflammatory infiltrates. It's very common in Black males with tightly coiled hair. At the early phase, the patients will present with dome-shaped papules at the nape of the neck, sometimes extending to the neck and even beyond the occipital scalp. Over time, it progresses to form papules. The lesions may be itchy or painful. Subsequently, development of keloid-like papules and plaques with scarring alopecia may occur, especially if left untreated. In severe cases, there may be draining sinus tract and abscess formation. Acne keloidalis nuchae is thought to occur either from chronic mechanical trauma, from tight collars, helmets, haircuts, especially in tightly coiled hair that curls back following haircuts, or shaved hair, leading to follicular injury and secondary inflammation. When this process is repeated, it contributes to scarring and keloid papules. Another theory suggests that it's as a result of aberrant immune response against central follicular antigens, which are very commonly seen post-puberty, which triggers perifollicular inflammation and sebaceous gland destruction, leading to follicular wall weakening and progressive fibroplasia. The second classification of scarring alopecias are the secondary alopecias. These are the types of scarring alopecia that occurs from external factors like tumors, which can cause scarring alopecia. These factors are not directly from scalp diseases. In addition, inflammation from infections like the inflammatory variants of tinea capitis, like the zoophilic forms, can actually cause severe, intense inflammation on the scalp, the hair follicles, and the hair shafts. And these individuals, who are often children, present with painful, boggy, inflamed scalp mass with pustules. And this is often associated with regional lymphadenopathy. Over time, severe scarring results. Now we go over to the non-scarring alopecias. Non-scarring alopecias can be focal, diffuse, or patterned. Alopecia areata is a non-scarring alopecia that typically presents with patchy hair loss. Of course, there are different various clinical patterns, and several sites can be involved, including other non-scalp hair-bearing areas like the eyebrows, the eyelashes. Patterns like the ophiasis pattern affects the scalp hair over the occipital area, whereas the reverse, which is the sisal pattern, occurs where the occipital and the temporal areas are spared, leaving only the vertex area. And this can actually mimic male androgenetic alopecia. In alopecia areata, there may be associated autoimmune conditions including thyroid disorders, vitiligo, atopic dermatitis. Nail changes like regular pits can be seen and can actually help or assist in making a diagnosis. It's unpredictable and often runs a relapsing and a remitting course. Other variants of alopecia areata include the alopecia totalis, where the whole scalp hair, the entire scalp hair are affected. The eyebrows, the eyelashes may also be affected, the axial and the pubic hair. And in this case, where you have body hairs affected, it is called alopecia universalis. Another type of patchy non-scarring alopecia type is the alopecia syphilitica, which is actually called the moth-eating alopecia because it resembles moth-eating plants or moth-eating clothes. It's immune-mediated and presents with patchy multifocal irregular hair loss resembling moth damage. It's associated with secondary syphilis, and other hair-bearing areas may be affected. In the history of sexual activity, unprotected sexual activity can be helpful, and other systemic features like the typical rash, which is associated with a colourate of scale and is called beard sign, can be seen, especially on the palms and the soles. Lymphadenopathy may also occur. Non-inflammatory tinea capitis can also cause focal non-scarring alopecia. And typically, you have an area of patchy hair loss with broken hairs, which is called the black dot tinea. In addition, other variants like the seborrheic variant, where you may not have obvious patches of hair loss, but you see scales looking like seborrheic dermatitis, may often be seen. Trichoscopy and scalp scraping with microscopy or microbiological studies are often helpful. And in trichoscopy, features like the comma hair, the corkscrew hair, broken hair, even pustules can be seen. Trichotillomania is another cause of non-scarring alopecia. It is often psychogenic or behavioral in origin, where the patient has a compulsive urge to pull their hair. It's common in children, adolescents, and young adults, and the patient presents with irregular patchy hair loss with hairs of varying lengths. Interestingly, features of inflammation or scaling are not seen. The Freya-Tocq sign is typically seen in severe trichotillomania, and trichoscopy shows broken hairs at varied lengths. Other trichoscopic features include hook hairs, flame hairs, and hair dusts. Traction alopecia is one of the commonest causes of non-scarring alopecia among females with afro-textured hair. It is caused by prolonged tension on the hair from hairstyling practices like tight braids, wearing of hair extensions, dreadlocks, and even hair rollers. Of course, it's very common in these individuals of African descent due to their peculiar hairstyling practices. One of the key features is the fringe sign, where you have retention of hairs, typically vellus hairs, but sometimes even terminal hairs at the anterior hairline, with the posterior area having reduced hair density. This also highlights the fringe sign. In early traction, tenting of the hair with puckering of the scalp, surrounding scalp area may be seen, and pustules and papules may also be seen. Patient may also complain of pain following the hairstyling procedure. Pressure alopecia is another cause of non-scarring alopecia that is caused by restricted blood flow and temporary follicular ischemia by prolonged external pressure. And typically, it can be reversed with removal of the pressure source. Male androgenetic alopecia is the commonest cause of hair loss in males and causes progressive pattern hair loss. It is genetically determined, and there is androgen-mediated miniaturization of follicles in areas that are androgen dependent, like the bitemporal areas and the vertex, with sparing of the occipital scalp. Its onset is often in the late teens to early 20s, especially in individuals who have the genetic predisposition. As it progresses, thinning of the vertex with eventual balding of the vertex can be seen. The Norwood classification actually classifies the progression of male androgenetic alopecia, as we can see in the female pattern hair loss is another cause of non-scarring alopecia that presents with diffuse central thinning with preserved frontal hairlines. Unlike in males, it is not linked to androgens in majority of the patients, and it can be familial. It usually presents after age 30 and worsens with menopause. The Christmas tree pattern at the midline is typical and is associated with other genetic causes and endocrine pathologies like polycystic ovarian syndrome and the Ludwig classification is used to grade progression in female pattern hair loss. Now let's look at hair loss due to alterations in normal hair cycling processes. Telogen effluvium is a non-scarring diffuse hair shedding due to a premature shift of anagen hairs into the telogen phase. It can be acute or chronic. It occurs 2 to 3 months after the triggering event. And these causes include medications like drugs, for instance, beta blockers, anticoagulants, psychological or emotional stress, surgeries, endocrine abnormalities like hypothyroidism, metabolic disorders, chronic diseases like chronic kidney disease, rapid weight loss, crash diet, nutritional deficiencies including iron deficiency, acute systemic illness including COVID-19 infection have all been associated with anagen effluvium is a non-scarring type of hair loss characterized by rapid alopecia due to disruption of the anagen phase of the hair cycle due to damage to the hair matrix cells. It often occurs due to chemotherapeutic drugs including antimetabolites and radiation. Trichoscopy shows thinned, broken hairs. Loose anagen hair syndrome is a benign sporadic non-scarring alopecia where anagen hairs are defectively anchored in the follicle. It commonly affects children, often girls, with blonde or light hair, but may also be seen in the darker hair. The hair appears short, sparse, does not grow long, and they are abnormally and painlessly extracted from the scalp. Diagnosis is often confirmed by trichogram, and it shows more than 50% loose anagen hairs with ruffled cuticles resembling the hockey stick. Now we go on to the hair shaft disorders. Moneiletrix is a structural hair shaft disorder with increased fragility of the hair. It is also called beaded hair. It is inherited predominantly in an autosomal dominant manner, although autosomal recessive variants can also occur. The hair is normal at birth but becomes short, brittle, and sparse within the first year of life. The occipital scalp shows more prominent low hair density than the rest of the scalp areas. The eyebrows and the eyelashes may also be affected. Trichoscopy shows regular nodes with narrowings in between along the hair shaft, and these areas of narrowings are the areas where the hair easily fractures, like these areas. The nails may show koilonychia. Trichorexis nodosa is a common hair shaft disorder associated with weak points which appear as nodules on the hair shaft, and these weak points cause the hair to break easily. Patient presents with short, sparse, brittle, and damaged hair, and they often complain that their hair does not grow. It can be inherited, and inherited forms are caused by either metabolic or genetic disorders like biotin deficiency, hypothyroidism, and Menkes disease. The acquired forms are frequent among Africans with Afro-textured hair and is thought to occur from damaging or traumatic hairstyling practices, including brushing, heat, chemical hair relaxers, and hairstyles. Trichothiodystrophy is a rare genetic condition that is caused by deficiency of sulfur on the hair, and hair presents as short, brittle scalp and eyebrow hair. The hair abnormalities do not improve with time, and it's often associated with other systemic diseases. It is autosomal recessive in inheritance, and the patient also presents with short spoon-shaped nails. often associated with ichthyosis, intellectual and developmental delays, and patients may present with recurrent infections, infertility, and ocular abnormalities. Polarized microscopy typically shows the alternating light and dark bands, which is seen as a tiger tail abnormality. Trichoretis invaginata, which is a hallmark of Netherton syndrome, is inherited as a result of a SPINK5 mutation and is autosomal recessive. Patient presents with brittle short hair with patchy alopecia. In this condition, a bamboo hair abnormality is seen on the hair shaft, and the distal hair shaft invaginates into the proximal portion, creating a ball and socket abnormality. Also, occasionally gulf T hairs can also be seen. Now, how do we evaluate patients with alopecia? The history is very important to determine the diagnosis and also to ascertain possible cause and triggering factors. You want to find out the onset of the hair loss, the duration, and the progression. Sites of affectation are important, as we know that hair loss types like alopecia areata can affect other body hairs. Frontal fibrosing alopecia can also affect that. You also want to know the extent of hair loss, whether there is associated hair breakage or if it's hair shedding, as can be seen in telogene effluvium. A history of compulsive pulling of the hair may also suggest trichotillomania. Associated symptoms like itch may be seen in some scarring alopecia types or even in infectious causes like in tinea capitis. Pain, tenderness, and dysesthesias can suggest scarring alopecia. Sexual history is very important if a patient presents with moth-eating alopecia type. Hair care practices, as we can see, are important. Drug history, associated medical conditions like hypothyroidism, PCOS, that's polycystic ovarian syndrome, is also important. The family history. In addition to the history, a good physical examination should also be done, starting with visual inspection of the scalp with good lighting to assess for features of inflammation, scarring, or scale. The part width should also be assessed. The hair shaft should also be examined using a contrast technique where a black or white paper is used with respect to, depending on the color of the hair shaft, looking for blunt tips, breakage, or split ends. A full skin examination, assessing the teeth, the nails, and also assessing for features of hyperandrogenism like acne, hirsutism, and clitoromegaly are also very important. Hair fragility testing can be done by grasping the proximal and the distal portions of the hair shaft, about 25 to 50 hair shafts, and gently pulling them apart to assess for increased fragility of the hair shaft. A general examination also is very important to assess other. A hair pull test can also be done to ascertain active shedding of the hair, as can be seen in acute telogene effluvium or acute alopecia areata. Here, about 25 to 50 hair strands are grasped and pulled gently. And then the extracted hairs, if they are more than 5, suggest active hair shedding. And these extracted hairs can actually be reviewed using the light microscopy to be able to assess the number of anagen versus telogene hairs. And this can aid in the diagnosis of conditions like telogene effluvium. A trichogram can also be done here using a needle holder. About 25 to 50 hair shafts are grasped and gently pulled, and the hairs that are pulled out are analyzed using light microscopy. In phototrichogram, a modified version of trichogram, here a device is used. First, the hair is clipped short and a device is used to take photographic pictures of the areas of the hair shaft, analyzing the anagen versus the telogene hair ratios. Thereafter, after some days, this picture is also repeated, and then the growth phase, the active growth phase, the anagen phase are noted, and also the hair density can also be compared if there is improvement in them. Yes. A light microscopy can also help, especially in hair shaft disorders, as we have. Trichoscopy has emerged as a non-invasive procedure that can be used to assess hair parameters, including hair shaft, follicular openings, perifollicular and vascular changes, and disease-specific hallmarks can actually be seen and aids in making diagnosis. Scalp biopsy is performed in situations where the diagnosis is uncertain, especially in scarring alopecia types and in non-scarring alopecia types where trichoscopy or other non-invasive procedures are unable to help us establish a diagnosis. Laboratory investigations are also important. depending on the particular suspicion. So in conclusion, our take-home message here is that alopecia means hair loss, and it's also important to note that there are certain contributory factors, including genetics, diet, drugs, that can actually worsen or even cause alopecia. Overlap can happen, and it's important we think systematically so that we can recognize these diseases early. Remember, time is hair, so early recognition of especially scarring hair loss types and early treatment can actually avert irreversible hair loss. So it's important to recognize early, diagnose carefully, and act systematically. I'd like to thank Professor Joanna Trivara for sharing some of her pictures, and I also like to thank Professor Rudniska, a dear teacher and a mentor. Thank you so much for listening, and I'll be happy to take questions.
Thank you very much. You can follow us on all our social media platforms to learn about upcoming events, webinars, programs, and more. And you can also get involved with us by being a member of GLODERM by scanning at the top right-hand corner. Thank you very much and have a lovely day.